Okay, everyone, it's 11 o'clock on the dot, so I think we should start. For you and who are actually on time, just a small personal anecdote. I'm actually from this small country called Singapore, many kilometers away, and we pride ourselves on being the Switzerland of Asia. So we're real, about punctuality. So we're going to start at 11 o'clock, but also because we have a really interesting final session for the day. We've looked at health tech from tech and pharma, how they collaborate with the ecosystem. We've had three fantastic startups sharing really hands-on their diverse journeys towards commercialization. And now we will look at the health technology assessment and market assess perspective with speakers from Germany, Denmark, and Sweden to help round off our time together. And it's my pleasure to invite our first speaker from Germany, Dr. Philipp Kirscher, Director of Data Protection and Medical Law from the Health Innovation Hub in Germany, to share their experiences from their groundbreaking work with the digital health applications, or DiGA for short. So Philipp, take it away.
Thank you, Sarah, and thank you for having me today. I'm very honored to be here and to present a little bit about what we're doing. I am one of the members of the German Health Innovation Hub, which is a sort of a think tank project of the Federal Ministry of Health. We've been there since, spring 2019, and we will dissolve in the end of the year. So this is one of the last talks that we're going to do on the topics that we've been addressing. Our task was to advise the ministry in questions of digitalization of the healthcare system, and we did so as an interdisciplinary team, having a pharmacist, having physicians, having people who know data and AI, and also that was necessary, of course, to have a lawyer on board. That's why I'm in this team, and we did work on a series of legislations within the last legislature. We've had elections in September this year, and the last Minister of Health, Jens Spahn, has been very much focusing on digitalization in the healthcare system. So we had a number of laws, and of course I'm not going to go through all of those laws. We're only going to focus on the lower one, the DVG, Digitale Versorgungsgesetz in German, and that is the Digital Healthcare Act, which brought a new thing into our social code, which we call the DiGA Fast Track. Before we had the DVG, there was an evaluation on how good is Germany in the digital healthcare so far, and you can see that we've been second from the bottom, so place in 16 in this evaluation. We really didn't do so well at that time. Of course, the ministry saw that many new solutions were developed. People were using smart wearables, smart devices, using health apps, fitness trackers, all of that kind of stuff. But they didn't really know how to cope with that. So what they did is they did 5 projects funded by the Ministry of Health to get an understanding on what's happening with digitalization in the healthcare market. So the first thing, of course, was, are there any opportunities and are there any risks? And what are the risks if we actually go for digital health applications?
Then they try to somehow find out how to evaluate those solutions that are on the market, because you only have ratings on app stores, but what is that worth?
Then to develop a catalog of criteria that you would set up as a regulator to actually make sure that all the quality in such a project is represented as you want it. And then there was a project which I was actually a part of as a lawyer at that time, not being in the Health Innovation Hub at that time, but working at a law firm, on how is the access to the market being regulated, and what prevents digital solutions from actually entering the German market. Because we know there are many solutions, but almost none of these solutions made it into the German market. And so we kind of analyzed what are the hurdles to actually get there. And the last project was one that was actually in parallel to the actual lawmaking process, trying to find out what are the best, let's say, criteria for the standard of evidence that you need to actually show what your model will be worth for a system as it is in Germany, a statutory health insurance system. So this is one of the findings that we've had before. We looked at the different regulations in Germany, looking at what pathways are there to actually get into the market. And we saw that there were two which were actually open for digital things like the trial methods and the disease management programs, but they were pretty new and adjusted to digital pathways. They took quite some time. We didn't see any solutions in that so far. What we saw was that people went for the integrated care contracts, so selective contracts with the German health insurance funds. You now have to know that Germany has more than 100 health insurance funds, and so you have to do all the contracting work 100 times. Different criteria, different evaluation methods, usually just a short period of time where you can use this contracts for, different pricing models, everything is new every time you do that. This is not the perfect way. Which didn't really work out, although it wouldn't be prohibited, was to actually treat them as a medical aid or Heilmittel, which I don't really know a good translation to. So meaning that you're getting treated by non-professional physicians, but for example with a physiotherapist or as such. Because software isn't a physical thing, so it doesn't fit into the section 33, and software isn't a personal service delivered by a person, natural person, so it doesn't really fit into that one, and we didn't really have a clear pathway for the DiGA. So DiGA is short for digitale Gesundheitsanwendungen. So in English you would probably call it a DH if you have a digital health application, but as this is kind of a trademark now, we're using this one. And we've invented the German digital health applications fast track. So at first we should talk about what is a digital health application in this definition. You have to be a medical device after MDR, so the medical device regulation. It's only applicable for the risk classes 1 and 2A, so only the low risk medical devices can be a part of this process. Your main function has to rely mainly on digital technologies. Why is that a criterion? Because maybe you have some hardware. That is okay if the hardware and like the physical thing a hardware can do isn't the main driver for the innovation. And you could also have some kind of blended care if you incorporate some of the physicians maybe to take a part in this and actually do what they're doing with the services they provide as a person. But it may not be the main thing then. The intended use is centered on patients. We've heard that before today. So the idea is to have an app, software, browser-based, whatever it is, that is being used by the patient. And it is something that you could prescribe for a patient and give them just as you would do with crutches or with pharmaceuticals. And not something that can be used in a hospital by the hospital staff. And then you have some functionalities. So you have a detection of treatment, the treatment, palliation, alleviation of pain, compensation of diseases, injuries, and disabilities. What's maybe interesting on the other, like in a converse way to say is what's not in it. It's not primary prevention, and it's not, for example, things like birth control. You couldn't get this into the fast track. What you need to do to get a reimbursement with all of the statutory insurance funds is to get listed at the DiGA registry at the German Agency for Drugs and Medical Devices. If you're listed, every physician, psychiatrist, and actually the health insurance funds themselves can prescribe or grant your solution to a patient. You have to fulfill, of course, some of the requirements here. You have general requirements that are necessary to be fulfilled, for example, for the safety and quality of the product, data protection, data security, also including a big part is the interoperability of your product and the data you're using. And then the second part is the positive care effect. So you would usually go for a medical benefit probably that you would have to show your solution can provide. This is a bit broader. This also refers to structural and procedural effects that come in handy for the patient in the individual situation. You always have to fulfill the general criteria requirements. If you fail on showing that you fulfill them, you will not be listed. If you cannot already show the positive care effect, there is actually a way around that, so you're not probably, as we heard before, dying by pilot, but you can use your pilot and actually get a preliminary listing for 12 months in a trial period in which you will have to gather all the evidence to show that your solution actually can fulfill the medical benefit or the structural and procedural effects. During that time, you are already in the catalog of standard care, so you're getting reimbursed with a price that you are setting yourself as a manufacturer of this solution. But you also have to show, of course, and make plausible that you'll be able to create the evidence you need within the first 12 months. After 12 months being in the system, and that goes for preliminary listing or final listing from the first day on, there will be negotiations about the price that you'll be reimbursed. And that goes with the association of the German health insurance funds, so the main association of all health insurance funds, and that's why you have a price that is the same price for every health insurance fund and every patient who's in this health insurance system, which is 90% of the Germans, so it's roughly about 72 million people, and that may be your customers then in the end. If you want to read more about the things you have to prove, I put up some links where you find the Digital Health Applications Ordinance, which is a sub-law which can be changed by the ministry itself without involving the parliament again, which is the first QR code. And there is a guideline which is also available in English by the BfArM, giving you actually a comprehensive understanding of what you have to show and to be able to actually be listed with BfArM. So we've introduced a new kind of category to our evidence. So we have the medical benefit, of course. You'll have usually the patient relevant outcomes here that you could, and endpoints that you could focus on. But we also opened this up for these structural and procedural effects. So other things that health technology assessment can focus on that may be relevant for a technical solution and that may have a benefit after all, which may also in this second layer be a medical benefit then, but that we think can improve care, and that could also focus on the maybe problems that you have in your country, granting care from the next day on. Maybe you have waiting periods or something until you have your next appointment, and sometimes solutions like this can help you during this period to cope with your disease.
So this also means that we could address these aspects with other research from other health technology assessment domains.
So we have a whole new field that can be a new playing field also for researchers trying to find the right way to actually show that other HTA parts are relevant for us. I said before, after the trial period or after the first 12 months, you will negotiate a price, and for the price, of course, the evidence you provide will be crucial, because there is really not much said how the price is going to be defined. It's just a negotiation.
So you will have to prove that what you do is actually cost saving or provides better care. You are negotiating this with the statutory health insurance funds, who are, of course, very much interested in cost savings. The DiGA directory, maybe to just introduce this a little bit, is an online platform that anybody can access. It has information of all the listed DiGAs. Right now we have 24 of them within 1 year. You can find the indications, the contraindications. You can find if they're preliminary listed or not. You can find the prices. You have filter options, and you can actually, because it's an open API and it's an interoperable system, use whatever software you're using in your hospital or in your practice to access the data and implement it in your system. So while prescribing, you can just access the data from that, and you don't have to switch to a browser and go online. Some KPIs that we've tried to gather. It's not the easiest thing to do because the first report on DiGA will only come out at the end of this year.
So we have 25 DiGAs listed, and that means 2 per month right now. We've had many more applications from different countries. I know there are also 2 applications from Sweden, and
Many struggle to actually provide the evidence they need. That's mostly the reason why they withdraw their application or not get listed in the end. We only have 25% of DiGAs who are listed permanently right away. So the majority goes for a preliminary listing. What we also saw is that all the manufacturers who made it into the DiGA directory so far went for RCTs. Maybe some learnings from a more institutional point of view.
we saw that it takes way more time than we thought to create the new bodies. We have a self-governed situation in Germany, so you have associations of physicians, associations of hospitals, associations of the health insurance funds, and so on, who are negotiating this. And we didn't have an association of DiGA manufacturers, of course, before, so they would have to gather around and build new bodies, arbitration bodies, for example.
With all of them, knowledge had to be built up concerning this new process and, of course, digital therapeutics in general. So if it's with the BfArM as an authority or with the notified bodies. And now we have the hurdles to actually get the knowledge to the patients and also, of course, the physicians. We don't really have a certificate to prove everything that we need. So data protection, data security, interoperability. We don't have anything that you can just put on your product and show that you're actually meeting the criteria. We have an extensive list of more than 142 questions that you will have to answer in order to apply to get into the DiGA directory. Of course, pricing is difficult, and I'm not telling you anything new here, but we, of course, have the opportunity, because we have a digital device here, to use the data we have to go for a different pricing model based on how much the product is being used or how good the outcome is if you will use patient-reported outcomes, for example. Fully integrating this in a healthcare system which has been there since the 19th century is pretty difficult. And we are lacking some statistics right now because the first annual report will only come out at the end of December this year. We only have some information that we can gather from BfArM. If you want to know more about the DiGA process, I of course can recommend the DiGA guide, which is very comprehensive. We also wrote a book on this, which we've been translating to English now, and I brought one copy with me, which is outside, and you can have a look at that. And we're really happy to see that a meeting like this today is happening, and we have an exchange within Europe because we had our digital medicine conference and we've been discussing how we could get a harmonized market for digital therapeutics in Europe. Because right now there is no real harmonization process in the EU, although Macron said that France would replicate what works in Germany. To wrap it up, these are the main questions that we have identified. If you want to have a look at the video, you have the QR code here, so you can go on YouTube and watch that session. We thought it was very fruitful. So now I may just say thank you very much for your attention.
Our next speaker, Christian Kidholm, he is the member of the Danish Treatment Council and professor and head of research at the Center for Innovative Medical Technologies from Odense University Hospital and the University of Southern Denmark. And Christian, we look forward to hearing your perspectives on how you're approaching digital health tech from a Danish perspective.
Forward to how many I will talk together with in this presentation, but we'll see. I'm working at a university hospital in Denmark, and we do development and assessment and research in new digital services. And I think we have the largest telemedicine research group in Denmark. We have 10 senior researchers and 25 PhD students doing design and assessment of the value of digital health services. So I'm very glad to be able to give a short presentation on reimbursement in general in Denmark, and a bit about some experiences we have with assessment of digital health services First, a bit about the new Danish Health Technology Council. That is sort of the national board for assessing the value of new technologies and also determining whether they should be reimbursed or not. And then a bit about the reasons behind, and then some lessons learned after many mistakes. My presentation here is actually quite similar to the previous one about what is important when making decisions on reimbursement in Germany. Then it's actually quite similar in Denmark. The National Treatment Council, or what's called the Danish Health Technology Council, is actually the correct term, is including these domains or elements in making an assessment of whether reimbursement should be made or not. So what is needed by the council is information about what's called the clinical questions, and I think that was similar to what previously was called sort of the medical benefits. So you need to show improvement in morbidity or mortality of patients. You need to show the level of evidence, and this is done by the GRADE tool. You need to show impact on patient safety. So that's sort of the first and sort of the most typical ones to look at when demonstrating a value. Then you need to show impact on patient perspective, satisfaction, empowerment. And then in addition, you need to show how does it impact the healthcare system. So there might be some positive outcomes when it comes to how we organize healthcare in Denmark. So it might improve work environment and make work for the nurses less stressful, and there might also be some economic outcomes. And that by the Treatment Council, they would like both to have sort of a classical health economic evaluation, like a cost effectiveness analysis, but they also would like to see the budget impact. So these are the 4 domains that producers need to demonstrate to get reimbursed. And in the same way as in Germany, you need to come to the Treatment Council with this information and put it into an application, and then on the basis of that, the Treatment Council will say, yes, this does show value for money, or no, we think this is not ready for being reimbursed. And I just brought this with me. This is the European HTA model by the UNETA organization. And this is actually what's behind the Danish council, and this is similar to what's behind the German model. When it comes to the economic aspects, we are requesting an health economic evaluation, and that could be a cost analysis or cost effectiveness or cost utility analysis. You need to demonstrate the economic impact compared to usual care. You need to have either a clinical study or a model-based study. And then the perspective, which type of costs need to be included. You need to look at, well, how much do you need to pay for it, and what is the impact on healthcare system, social care, and also the patient's time. So in the model, has actually put an amount of money, and I think it's about 300 Danish kroner, on the savings of time. So if you can demonstrate that the use of this service will, for example, reduce transportation time for patients with 8 hours, well, then you have shown a large societal benefit. And I do think that's really important, that this is very explicit in the model, that patients' time do have value. A bit about the reasons behind. Well, first of all, the Danish regions wanted to make sort of one door. You don't need to go, and as was presented previously from Germany, you don't need to go to many hospitals and regions and funds. There's one door for the Danish healthcare system. And then the thinking behind is also, and that was described by the chairman of the Danish regions, Stephanie Lose, that you need to show value for money. That's actually it. You need to show that this is the best possible treatment, and this will prove as much health as we can get for the money. So that's actually the thinking behind, and that's also sort of the traditional thinking behind HTA in general. And then we also need to look at safety, because, well, safety of the patients is extremely important for the healthcare system. So we need to be able to see that, well, by buying these services, we get value for money, but it's also safe, both for the patient and also safe for the staff, so to speak. So you need to show that this will not have any negative impact on the treatment of the patient and also on the healthcare system. So in some cases, we have seen that very nice devices actually resulted in a large number of patients who came to the hospital because the device was saying, well, you need to go to the hospital, and it was actually a mistake made in the device. So that kind of problem, we need to see that that's not present in the technologies that we buy. And this is just an example I found from a sort of very nice surgical robot that unfortunately made injury on a patient because it was actually not, it has not been sufficiently tested before we bought it in my region. So I think we have learned from that. So that was sort of the national perspective on how do you get reimbursed. Then a bit about the science behind this. How do you do science on these technologies? And this also reflected what we heard previously from Germany. And we have made lots of mistakes in the research we have done. And here are just 4 examples. And it's not mistakes in the way that it's bad science, because it's all of these 4 great persons made very nice PhD projects and made very nice publications in very nice journals. So they all succeeded in doing good research. But all of the 4 of them found that the kinds of home monitoring of patients with chronic disease did not have clinical impact, but had very large cost for the patient. So that kind of result, if you're not able to demonstrate clinical impact, but you can see that this will be very costly for the healthcare system. And in some cases, we're talking about 10,000s of kroners for each patient a year. Well, in that case, we don't have the money for it in the healthcare system, because we have a very fixed budget and also a very limited budget. We're not like an American healthcare system where you can just expand the budget. In the Nordic countries, you have kind of fixed budget. So we know from December the 1st exactly how much money we have. So we need to be able to demonstrate that the services we are using do provide value. And that was not the case in these 4 examples. So lesson number 1 is that you need to consider, you cannot just do a randomized control trial. And we have done that mistakes a few times. You need to consider the whole innovation process. You need to work on how to design, how to use co-production and co-design and patient involvement and participatory design as well, because you need to have the users engaged from the start, because otherwise they simply won't use your technology. So you need more than randomized control trial. You need to engage users from the beginning. And after you have done your trial and showing clinical impact, then you need to work on implementation, because you need to convince not just the doctor or the nurse who did the project, but the rest of the employees in the clinical department. And you need research for that. Secondly, and I also think that was very nicely related to the previous presentation, you need to be comprehensive in selection of outcomes. In some cases, digital health is about improving mortality and morbidity, but quite often, especially in the Nordic countries, well, telemedicine will not, it's sort of, we have collaborated, let me put it another way, we have collaborated with the government in Mexico, and in Mexico it might take 3 days for a patient with diabetes to get to a hospital where they have a doctor in who knows endocrinology and who knows the science behind the treatment of patients with diabetes. That's not the case in the Nordic countries. So it might be that in Mexico and in Australia and in Canada, telemedicine can save the lives of the patients. But in the Nordic countries, in my experience, telemedicine is very often about something else. It's about empowerment of patients. It's about reducing transportation a bit. And it's about making the life of patients with chronic disease more easy and less burdensome. And if that's the case, then you need to be comprehensive, not just look at the clinical outcomes. And I think there's an American model that was developed and presented in the summer about how to assess the value of digital services. And this model also very nicely reflects that you need to look at, of course, is the clinical outcomes the same, but you need to focus on, does telemedicine and digital services improve access to care? Does it give other types of benefits for patients and their families? So try not sort of to miss the goal. Try to look for other outcomes, and maybe actually patient satisfaction or patient empowerment should be sort of the primary objective, the primary outcome in your study, because that might be where the value is. And then finally, do we always need to do a randomized controlled trial? Well, of course the answer is not that we don't need always to do a randomized controlled trial. In some cases, it's sufficient to do other kinds of research. And when I talk to the medical doctors about this in our clinical department, I can see that they might have different views on this. In some medical specialties, they are very focused on the randomized controlled trial, but in other fields, they might have a different view on this. So there's not agreement on this area. But I think that we have learned over time that if you're talking about something very costly, that might cost 5,000 kroner for each patient, and you're talking about something that might have a serious impact on the health of the patients, both a positive but also potentially a negative impact, well, in that case, you need a randomized controlled trial. So are you moving patients with severe COPD from the hospital to their own home for home monitoring, and it's quite costly service, then you definitely need to do a randomized controlled trial. But are you talking about an information app to patients with mild low back pain, and this app can maybe help them do a bit more physical exercise and there's no cost? Well, then try it out with 30 patients, and if it's fine with them, well, then you have a good result. So you need to be sort of pragmatic in my view on this. So digital health technologies will definitely change how we run our healthcare system over time, and we are really, the curve is increasing on the proportion of patients who are using digital health services. Things has really started since last year, since the pandemic. But we need science. The producers need science to convince us and to convince the healthcare systems. And we also need the science to know that this does give value for money. And science is not just a randomized controlled trial assessing clinical outcomes. You need more than that. Thank you very much.
Thank you so much, Christian. I think that really complemented the German presentation. You could see some parallels, but also some differences. We'll come back to that in the Q&A, so make sure that you ask questions that will be addressed after the 3 presentations. So now we move from health technology assessment in Germany and Denmark to a Swedish municipality. And I would say that Helsingborg must be considered one of the most innovative municipalities, not just in Skåne, maybe in Sweden. I don't know, Johan, maybe you can answer that question. Johan Mullen Aspergen is the innovation leader at the Department of Care and Nursing at Helsingborg City, and you will talk about how you work with collaborative innovation. Thank you, Johan.
Yes, thank you so much. Hi, everybody. Johan Mullen Aspergen, innovation leader in Helsingborg City, and also I realize the guy standing between you and lunch. Yes. But it's been an amazing morning. Thank you for putting this arrangement together. It's been so interesting to listen to, and you know, when you're supposed to do a small talk, you listen to all the others and you try, oh, that's great, I need to sort of weave that into my speech as well. But I couldn't do that today because it's been too much. I would just, you know, be referring to the previous speakers. By the way, I'm here today to talk a little bit about getting from being a boring bureaucracy to actually driving digital disruption. Yes? All right, and we have the common challenges. And I won't really bore you with the challenges, the demographic challenges that we are facing, because everybody knows about it. We are getting older, the part of the population that is working and paying the taxes and financing it all is shrinking at the same time. And they also tell us that we are getting more needy, right? We are not as our parents or grandparents, we are actually having demanding services when we get old that weren't really sort of demanded earlier. So, so there's the big gargantuan challenge that we are meeting. But it's not only that, because we need to do this together. And when it comes to working together, because I've been in business before, I've been in academy before, I even tried to pitch a startup to a hospital once. So I've seen how hard it can be to work together with the municipality. And we all know about this. That's the regulations, of course. There's the procurement problem. There are the politics, we have external, we have internal politics. And this has been talked about earlier today. And it is tricky. And I think it's, I mean, there's no business really like a healthcare business. It is the most complex business that you will find. And also, I realized that there is a sort of, I mean, one problem we have when I talk to companies and startups is that we have different time scales. We know that for a fact, but there is also the problem with the conflicting goals, and I don't think we really addressed that enough. The company obviously wants to have I mean, you innovate or you die. If you can't innovate and stay sort of interesting, relevant to your customers, someone else is eager to take your place. As for the municipality, I don't really have that pressure on me, all right? Every 4th year there's an election, so I might get sacked, of course, if I don't do my work. But it's not like there is, like Varberg municipality will take over us. It's no. And we need to, so for us, I mean, when we talk about innovation and healthcare, it's about, I'd like to think at least, but it's about the strategic, it's about the big picture, it's about really getting more efficient quality care for a lower cost into the hands of our elderlies. Whereas the company, of course, have the bottom line. There's the revenue pressure, whereas I perhaps have the cost pressure. I can't spend as much as I would like to. And we need to have that in mind. And all right, so this model here, it's purely anecdotal. There's no reference whatsoever. This is based on gut feeling. So sorry for everybody who have a scientific approach to models of this kind. But this is something that I feel and recognize when I talk to my colleagues in other municipalities. So, and if you see this sort of municipal involvement on the vertical axis from low to very high. And here is the very, very simplistic innovation development phase, sort of, from ideation to development to some sort of market implementation, the adaptation part. And typically, or historically, this would be the case. We would not be involved at all, basically. With some few notable and bright shining examples, of course, but eventually at the end, we are requested to pay at least. But sort of the innovation takes part somewhere else, and then it ends up at our place. And I mean, some really good things have come this way, of course. The other thing, which is very, very important, which we see now, because now we're trying to do active innovation at the municipality. I even have a budget to spend for innovative ideas and prototypes and testing. And then we end up in another slightly different situation, and it's where we do all of it. So we have an innovation sprint together with nurses, and we come up with some real concepts and cool concepts, but there is no one really interested in taking this further on. So we call consultant company, and they help us to develop this, to prototype it. And still, there's no one that really wants to take care of this. So we end up also with the solution in our hand. And what I'm going to do with this, I have at least one AI-driven planner for a caring home in our drawer that we have evolved and developed together with the company, funded by Vinnova. And I can't for the world of me understand how am I supposed to use this. Right, so this is a big problem because I cannot create a business unit and sell this to Varberg. You know, I'm stuck with it. So what we need to do, because and this is being done, obviously, but I don't think this is the norm. This is not the typical way that we work. We would like to be much, much more involved in the beginning, during the ideation. We would like to take part of the development, but we don't want to carry or own or maintain or sort of develop the final solution, because you guys are much better than us at doing that. Also, I like to be a little provocative, and I will not be your business angel, because it's not my work, right? I tend for the elder list. I will try to make a system that works for us when we get elder as well, but we cannot be business capitalists. So, what do we bring to the table? We were talking about decreasing risk before, and I think here's actually the thing that we can do. Because I have 3,000 plus nurses, and they are working with our target group, our customer group, 24/7, 7 days a week. They're there. They know everything about Esther and Greta and Leif and Lars. And they tell me things. Each time I meet one of these nurses, 1 or 2 assumptions goes out of the window, because you get surprised every time. There's this brilliant nurse in America called Rebecca Lau. She says, nurses MacGyver their shift, right? They apply 27 workarounds every shift. They are very innovative, and they know stuff, and they want to be involved. So, I mean, we will be there. We want to be there. We want to be part of the ideation. We want to help you validate hypotheses and ideas and assumptions. We want to take part in prototyping and piloting. And I'll always want to help out and be the first customer, the empty restaurant problem. So we are very eager to help and to be there. But the thing is also, I think we talked about, there was a previous talker that said that it's a problem when contact persons leave. So you have a really good sort of cooperation with the municipality or region going on, and then that person, because the best persons always leave. So we need to put this in, we need to create models that are sustainable. We need to find structures that we can trust, that will be there also when the key persons leave. So we run since this summer something we call Testbed Careful AI. And this is based on the fact that we know that the most common reason for a startup to fail is no market need. All right, we've been asking our mothers too much. Is this a good idea? Mother, yeah, it's a cool idea. And then it turns out the market didn't really, the market wasn't really on there. So we want to help startups bridge this gap by offering the possibility to sharp and secure and excellent testing facilities early on in the product cycle. So as long as you have an AI solution or AI-driven solution aimed at healthcare and is not ready for sale yet, then we are super interested in inviting you to our test bed. And we have a dedicated coordinator to run this. We have benchmarked against the best test beds there are internationally. We put expert groups in this because we know we want to be covered when it comes to ethics and law and things as well, just as much as you guys want to be. So we do that together. And then we run a test project for 3 to 6 months to learn. And we had a really interesting project this summer. What on earth is avvikelserapporter in English? All right. Thank you very much. As soon as there's an incident at one of our home for the elderly, there will be a report written. And the masses of the reports are huge. I mean, that would be 3,000 reports per home, basically. And then there was this really cool company from Lund University that said, wow, we could put an AI engine on this to go through all these reports, because we can't do this ourselves, obviously, and sort of create clusters and learnings. And it worked. It worked. And my quality developers at the municipality are just blown away. This is such a great tool, and they want to have this. They want to have this. But now, sorry, it's just an MVP. It's not ready yet. It's not ready yet. It will be soon, though. Many hurdles, though, and it is very hard. to do this. Not only because of the data protection things, but it's doable, and that's the bottom line of it. So, to sort of top it off, do contact us. Hit me up on LinkedIn. It says that I don't want to connect, that I just want to be followed. That's just bollocks. I want to connect, right? So don't be shy. And call me or my colleagues about test beds, about data, about innovation, about hackathons, about design sprints. We want to take part. Thank you very much.
Thank you so much, Johan. Really inspiring. As I suspected, Helsingborg is very innovative. We're going to go into our final joint Q&A for the morning. I would like to invite back our speakers, Philip, Christian, and of course, Johan, please stay on stage, as well as our moderator for this session, Niels Christian Ganderup from Copenhagen Capacity, also one of our organizers for today's event. And before we go into the Q&A, please scan the QR code because we would like to engage you in our first and last poll for this session, but to really, in a way, wrap up all the discussions we've heard thus far. So please go into the platform, and I'm going to launch the poll now. And these are the questions that we have in the poll. Who has the primary responsibility for bringing new health tech or digital health solutions to the patient? Is it the politicians and the political system, healthcare providers, the industry, or patient organizations? We will hide the results for now as the discussion goes on, but please make sure you poll as well as ask questions. NC, take it away.
Thank you very much, Sarah. So, big questions, simple answers, that's always a good Q&A. Of course, it's way more complicated than this, so that's why we actually have the luxury of now having, the regulators here. So, I would like to urge you, there are a few questions, but do keep them coming, because you have them on the spot now. They cannot run away for the next 15 minutes. So you have the tough questions, and you get the answer on tape, so you can always sue them. So, let's get started. There was one with, actually it's about DiGA, but it's actually for Christian, because DiGA, Philip, you said the RCT, and that has been sort of the standard for DiGA so far. In Denmark, Christian, RCTs, digital health solutions, or real-world evidence, what are the options?
Well, it's the same for all kinds of health technologies. There's lots of options, and we do lots of randomized control trials of digital health technologies. So it does takes time, but and it is complicated, and you do need some money, and very often it's a PhD student who get the funding and do it as sort of the major part of a 3-year PhD project. But we do it quite a lot. And it is very good in many cases because you are very certain about the result. You have a high level of internal validity. You are quite sure when you find a difference between the telemedicine group and the control group, what is the reason for that, and that is the intervention. So that's the nice things about that. But as I said, in some cases you can it's okay to do less than a randomized control trial. So sometimes we see students who follow a cohort of patients and maybe compare them with a historic cohort. And we see also people using data from our electronic patient record system, and using the term real-world evidence. So all of this is possible, and you need to consider how can you, because in the end you have to be able to persuade or convince the clinicians. So consider who are those you have to convince. So if you're talking about, for example, if you're doing a telemedicine service in cardiology, well, the cardiologists are generally sort of quite tough, and they really do require a high level of evidence, and they have a strong tradition for doing a randomized control trial. But are those you're going to convince maybe in, and I have to be careful now, but maybe in sort of obstetrics, the level of, they are, one guy, a researcher in obstetrics once said, well, we don't have very good evidence for anything we do. So they are maybe maybe they're some more pragmatic. So know your audience, know the ones you have to convince. That's one side of it. And then on the other hand, also, well, you have to consider what study will give me sort of real good assessment of the true value of the service, because of course we need to make sure that the services are safe and do work and do provide clinical value.
Okay, good. Following on that track, and let's start with Philip and then move along with the next question, and short and sweet answers if possible. The whole real world evidence RCT focus, what can be done or should be done to move away from that? Because in the context of digital health, we don't have big deep pockets like pharma. So what can be done and how should it be done? Just like a few thoughts from the top of your head.
Well, as I'm a lawyer focusing on data protection law, this is quite a hard question for me to answer, actually. Right now, we're actually trying to move towards using real-world data more, and from a data protection point of view, the regulation is very, very strict right now, and we can't really use the data without having consent for that. I think we need a better framework for this one, but I think I'm a bit of the wrong person to answer this from a scientific point of view, because that's not so
Then
much
let's
my
pass it
point.
on to Christian.
Yeah, but in practice, real world evidence is very often that you take sort of 1 year, the patients who come to your hospital for 1 year, then you implement a new digital service, and then you follow the patients a year, the new patients who come and get the diagnosis and get the treatment. So that could be sort of using real world data, because the information about how often they see the hospital and their mortality, that kind of information, we have that in the system. So that is very often how it is done, but the pandemic is sort of the best examples of the troubles you will have if you do using real world data, because sometimes awful things happen. So suddenly and I mean, there must be hundreds of studies or thousands of studies that now is completely ruined, because they are comparing the patients from 2019, and they would like to compare them with the patients from 2021, and the world has changed. And the same thing can happen. We had a strike in Denmark among the nurses, so that also completely changed the hospitals. So it is very difficult, in my view, to do these real-world studies over time, following a cohort, doing an observational study. But in some cases, it can be done. But you need to be, in the end, you have to convince the clinicians.
Yeah.
So
I'm just gonna
the
interrupt.
idea is good, but
Yeah.
it's not easy.
No.
Yeah.
So
Yeah. Most been said, I think. But I mean, having real data, having good data from evidence and scientific studies helps in implementation. I would say that in any way. However, we don't always have the time to wait for that. And also when we're trying to do more, I mean, if we're venturing into more radical innovation area, it's very hard to know exactly what are we supposed to measure, because we know that we will be surprised as to the outcome. So setting up the measures beforehand and saying this is what we want to measure, that might be counterproductive if you're pursuing that process. So I mean, once again, this is a matter of being able to do to approach the problem in different ways. Sometimes the evidence and the clinical data needs to be there. Somewhere we need to be able to run things a little bit, winging it.
yeah, okay, thank you. So there are a couple of questions which relate to more the commercialization part and how to get there. And Philip, you're off the hook, because with DiGA you actually have a roadmap in Germany,
Okay.
which we don't
That's fine.
necessarily have yet in Sweden and Denmark. So to Christian and Johan, what is the twofold? What is the interest of actually bringing new solutions to the patients through the hospital and the municipal setting, and how can we expedite it? You mentioned both co-creation and stuff, but aside from that, what can we do, Johan?
Once again,
How can we bring digital solutions not the pilots, death by pilot story, but the the invoice to get companies up and running who can sell solutions to you and to the hospital. And how do we best do that, or how can we do that better? And is there a genuine interest in Denmark and Sweden to have these solutions?
Yeah, and this is definitely the 10,000 crown question, because innovation, as you know, that's easy. Implementation is hard because implementation involves people, and this is I wish I had a good answer, because this is the question I ask myself every day. And we have at least 38 projects that we are trying to implement right now, and I mean, anyone who comes up, I'm very curious as to listen here to what Karsten has to say, because I have definitely something to learn here. The interest is there, but the knowledge, so and so.
But I mean, if you go to any hospital in the Nordic countries, in any clinical department, they will have budget problems and they will have problems with staffing. They cannot find the staff. So if you have a technology that can, for example, reduce the number of outpatient visits by patients by using digital communication, if you can demonstrate that you can reduce from having 4 visits a year to 2 visits a year, and by adding digital communication, well, that will make any medical doctor and head of a clinical department happy, unless you are asking him to pay 10 million Danish kroner. But if you have a sort of a nice amount that is not completely overspending it, and you have shown that this can reduce the amount of work that needs to be done, and that will help him with his budget problems, he will always be open to you.
Okay.
Maybe I can just add that, I mean, this is a question that goes for selling your product to a hospital or to a physician's practice or something. And the DiGA is obviously not doing that. It's something that where you have a contract with the health insurance funds, so you have to convince them with the evidence. And of course, they look at the cost perspective, but in the end, it's something for the patient. There's a different law in Germany, the Hospital Future Act, which spends 4.3 billion euros on digitalization in the hospitals, because what they saw was that usually the budget in the hospital, which goes into IT, is very small, and it's just being used for things that can cut your costs usually. But it's never used to do like a big transformation process, because they don't have the people, they don't have the money, and if they actually want to use these new kinds of communication things, more telemonitoring, patient portals, releasing people earlier but still having a connection to them, you would actually have to ingest money, which in Germany has to be done by the state.
Okay.
But this has really been thriving the hospital sector for the last year.
Okay, super, thanks. I think it's time to pull up our poll results. So what, oh, I can see it down there as well. That is actually quite interesting. I mean, it seems like, Christian, you're off the hook in terms of the hospital. It's really down to politicians and industry. And I guess that leaves the healthcare providers, such as, Christian, sort of stuck in the middle, if I may say so. The question I would like to ask then, now you see the results here, just a quick comment from each of you, if we start with Johan, on what do you think of this? I mean, do you agree? Is there anything wrong with this picture?
No, I mean, I want to see the ski slope where we do it together. I think we need to do this together, and not only business and the healthcare industry. Also, I mean, the hospital and the primary care center and the municipal care. We need to find to identify the key parts of the ecosystem to get this to work. There are accelerators, there are mind parks, there is the test beds, there is the sort of the finance, the business angels, and realizing that it all needs to connect together. That's one part of it. The other part of it is that we desperately need to come up with new business models for these. I mean, the telemedicine is a very good example. I mean, if I have full sensor on my elderlies, I am perhaps not the guy that is really harvesting the financial benefit of that. That might be the hospital. So we need to find ways to make the finance flow in the correct way. That, I mean, we're good at value creation, but I think we are worse at value capture.
Or capturing value at the right place from an incentive perspective. Christian?
Well, I can only speak for Denmark, but and this is a bit unusual for me, but I'd like to sort of say that the politicians actually are doing a very good job on this, and there's lots of digitalization strategies for healthcare from the government, from each of the regions, and also from hospitals. So I really do think that the politicians do have seen that this can solve some of the problems we are facing right now in Denmark with lack of staff. I think you need to, as a company, you need to go to the healthcare providers, to the hospitals, and also to the doctors and the heads of the clinical departments, because if they can see it, they will go back to their manager and say, well, I have seen this, and this can actually help us in this situation. So go to the medical conferences and present the stuff you have, and provide them with evidence. Then I think you have a way forward.
And evidence does not need to be an RCT.
But consider what is needed to demonstrate value, because they will be critical and they will ask, are you really sure that this is the effectiveness? So you need to come up with strong arguments, and if you can do that by real world data, then that's of course fine.
Super.
If you would have asked me this question 5 years ago, I would have said the industry. And of course, they should involve patients and the healthcare professionals when developing new products, because I mean, in the end, they want to earn money with it. But as I've experienced throughout the last 2.5 years, the difference it makes if the regulatory framework is innovation friendly, that can change the whole picture. And so I would agree that the responsibility here actually lies with the politicians and the regulators to actually review their healthcare systems and look in what are the hurdles actually preventing innovation from getting into the market.
Super, thank you. I can feel a presence, a timekeeper. So I think we should give the three gentlemen a big round of applause. And
Thank you as well, NC, for wrapping up the discussion so well for us. So we've had 3 hours of really good discussions and insights looking at health tech from many different perspectives. And of course, the conversation doesn't stop here. We have a special lunch planned for all of you. It's right out up the stairs. So not just outside, but go one level up, and it's dedicated for you. So make sure you have some lunch before you go and meet some new contacts. So on that note, I just want to thank you for joining us today. Watch out for your email. You will get access to the recording and presentations in a couple of days. So my name is Sarah. Thank you for joining us at HealthTech Medicon Valley.